Ladies and gentlemen, will the congregation please rise?
Sit down. Good evening, ladies and gentlemen. My name is Ian Jandrell. I'm Deputy Vice Chancellor, and I have the absolute privilege of spending some of my time with the Faculty of Health Sciences, learning all sorts of things which, as an engineer, I know very little about, but it's an absolute privilege to be here. My job this evening is actually a very, very simple one. Firstly, it's to introduce the procession. And of course, in the procession, we have Professor Shabir Mahdi, the Dean of the Faculty of Health Sciences, Professor Helen Rees, the Executive Director of the Wits RHI, and of course, our inaugurating professor, Professor Sinead Delany Moretlwe. Now, I tried very hard to get that right, and I'm not going to put her under any further pressure, but I do want to say the following, that inaugural lectures are remarkably special things. And I want our inaugurating professor, who is going to profess tonight, to really remember that you're talking to friends, loved ones, and family. And I think that's very important. This is that moment, that passage that you go through as an academic, when you share what drives you, what excites you. And we're all here to support that. So we are really looking forward to listening to you this evening. And I want to start by just recognizing that it's an incredible achievement, and congratulations. What I'd like to Now, when I was a dean, I also learned that dean stands for do everything at night. So I'm going to ask the Dean of the Faculty of Health Sciences, Professor Shabir Mahdi, to introduce our inaugurating professor. Professor Mahdi.
Thank you, Prof. General, and good evening, colleagues, faculty, and guests of Professor Sinead Delany Moretlwe. So as the Dean of the Faculty of Health Sciences, it really gives me the pleasure to introduce Sinead. Sinead is currently the Director for Research at the Wits Reproductive Institute of Health and Professor of Global Health and Infectious Diseases at the University of Witwatersrand. Her research interests span the intersections between sexual and reproductive health and HIV, particularly in women. Her early doctoral work focused on potential for herpes treatment to reduce HIV acquisition, transmission, and progression. She has been an investigator on several phase 3 trials of new HIV prevention technologies. She has also focused on strategies for prevention of HPV-associated cancers in people living with HIV, and her work has supported HPV vaccine introduction and subsequent impact evaluation in South Africa. The current focus is on the development of new diagnostics, therapeutics, and vaccines for the prevention of other STIs, especially gonorrhea. She works with an extensive network of local and international collaborators and is also an advisor on several South African and WHO advisory committees. So with that introduction, Sinead, congratulations, and please come forth.
For giving me the opportunity to share with you my experience of advances in the prevention of HIV and other sexually transmitted infections, from stigma to solutions. So in 2023, an estimated 40 million people globally were living with HIV. Almost the same number, 42 million globally, have died of HIV since the start of the epidemic. The WHO African region continues to be the most severely affected, accounting for 2/3 of people living with HIV worldwide. And it also accounts for 50% of the global new HIV infections. 3/4 of adolescent girls and young women who acquired HIV in 2023 live in sub-Saharan Africa, and HIV prevalence in adolescent girls and young women is 3 times higher than their male counterparts. Several studies have confirmed the cycle of transmission from young and middle-aged men to young women, and that explains the high incidence in young women. Social factors like poverty and limited livelihoods encourage transactional sex. But long-standing gender inequalities, discrimination, and poverty deny many women and adolescent girls the economic autonomy and deprive them of control of their sexual lives and expose them to the risk of emotional and bodily harm. And these factors all increase the risk for HIV. 55% of new HIV infections occur among populations who may be at increased risk, likelihood of HIV infection because of social determinants, structural barriers, and poor access to prevention. Transgender people have a 20 times higher risk of HIV infection. Men who have sex with men have a 14 times higher risk of HIV infection. People who inject drugs also have a 14 times higher risk of HIV infection. And sex workers have a 9 times higher risk of HIV infection than the general population. These populations face social and legal barriers to safely accessing HIV services in some contexts. And in some contexts, the response to HIV has stalled and even reversed, exacerbated by the introduction of laws that further criminalize and marginalize these populations. In a review of HIV prevalence and antiretroviral therapy amongst key populations in sub-Saharan Africa, HIV prevalence was, on average, 4 to 6 times higher than the matched total population prevalence, and antiretroviral coverage was lower than the total population, reflecting the barriers that these populations experience in access to healthcare, even in generalized epidemics. So according to WHO estimates, in 2020, more than 1 million new cases of curable sexually transmitted infection caused by 4 pathogens, syphilis, gonorrhea, chlamydia, and trichomoniasis, were acquired each day and were responsible for 1.3 million disability-adjusted life years, which is a measure of the burden of disease. The burden of STIs is uneven between and within global regions. Overall, the prevalence and incidence of infections is highest in the WHO Africa region. And although men had the highest rates of new HIV infections, women had the highest burden of disease in terms of DALYs. Mother-to-child transmission of sexually transmitted infections can result in poor pregnancy outcomes and infant outcomes. In the last 2 years, we've seen a rise in the number of new cases of syphilis globally in adults 15 to 49 years, with the total now estimated at 8 million cases. The estimated number of congenital syphilis cases, that is, infections in infants of pregnant women, was estimated to be 700,000 cases, with a case rate of 523 per 100 live births, which is 10 times the elimination threshold for vertical transmission of syphilis. The number of adverse birth outcomes related to maternal syphilis infection was 390,000, and just over half of these resulted in stillbirths or neonatal deaths, while the remainder have poor long-term health outcomes in infants and are associated with significant costs to the health system and to their families. We're also faced by the threat of increasing antimicrobial resistance of gonorrhea. 1 in 3 countries reported decreased drug sensitivity or resistance to ceftriaxone. Faced with limited antibiotics options, WHO added Neisseria gonorrhea to the top 10 list of priority pathogens for new drugs and vaccines to prevent antimicrobial resistance. STIs can also increase the risk of HIV acquisition or transmission. 520 million people aged 15 to 49 are living with genital herpes in 2020. Women are affected more than men, and slightly more than a third of people had symptoms of genital herpes in the past year. Despite that, genital herpes costs $35.3 billion international dollars in 2016. And HSV increases HIV risk by 3 to 5-fold. STIs also account for 1.2 million new cases of cancer in 2021. Cervical cancer is caused by persistent infection with human papillomavirus, and human papillomavirus is a common sexually transmitted infection. Almost all sexually active people will be infected at some point in their lives, and usually without symptoms. In 9 out of 10 people, the body controls the infection by itself. But persistent HPV infection with high-risk HPV types is the cause of cervical cancer and associated anogenital and oropharyngeal cancers. Cervical cancer is the 4th most common cancer in women globally, with around 350 deaths in 2022. And the highest rates of cervical cancer incidence and mortality are in low and middle-income countries, reflecting disparities in access to health care. Women living with HIV are 6 times more likely to develop cervical cancer compared to women without HIV. Men are also susceptible. Almost 1 in 3 men worldwide are infected with at least one genital HPV type, and around 1 in 5 men are infected with one or more high-risk HPV types. So HIV, HPV, and HIV, HPV, and other sexually transmitted infections are global health problems. But what is global health? So global health focuses on issues that directly or indirectly affect health, but can also transcend national boundaries. It focuses on issues that are directly or indirectly associated with health equity among nations, and that is the primary objective. The development and implementation of solutions often requires global cooperation, and it embraces both prevention in populations as well as clinical care of individuals. Highly interdisciplinary and multidisciplinary within and beyond health sciences, global health emphasizes the mutuality of real partnership and a pooling of experience and knowledge with a two-way flow between developed and developing countries. Global health thus uses the resources, knowledge, and experience of diverse societies to address health challenges throughout the world. So how did I land up working in global health? Well, I grew up in South Africa at a time when apartheid was a legal system that promoted racial segregation for the purposes of securing white control. Apartheid not only limited access to quality health care for black people, but also created an environment which abuses such as the refusal of emergency treatment, falsification of medical records, and mistreatment of the mentally ill. National health expenditure was allocated to building a medical infrastructure that would be used by urban inhabitants and the privately insured. As a result, marked disparities in health indicators between blacks and whites emerged. For example, the infant and maternal mortality rates were staggering in their differences, as was the incidence of TB and death by homicide. I stepped into this healthcare crisis as a medical student. The day I arrived at university, the ANC and other organizations were unbanned. A week later, Nelson Mandela was released from prison. And in my 4th year, the first democratic election in South Africa was held. As a young doctor, I looked forward to the promise of healthcare as a right for all. But that was not to be. In 1990, HIV antenatal seroprevalence was less than 1%. HIV was considered a disease of white gay men. But within 5 years, antenatal seroprevalence was 10%, and by 2003, nearly 1 in 3 pregnant women attending public hospitals tested positive for HIV. In those early years, we had no antiretrovirals. We sent people home to die. HIV was associated with enormous stigma and shame, and despite the promise of a national health plan, the HIV response was a lower priority than nation building and a peaceful democratic transition. But worse was to follow. AIDS denialism by the President and his health minister led to a reluctance to introduce antiretroviral treatment programs into the country. Several explanations have been posited for this attitude, including deep skepticism and mistrust regarding the motives of the pharmaceutical industry, belief in conspiracy theories, that HIV was manufactured by apartheid spies, and a reaction to stereotypes of black African masculinity and sexual promiscuity. Many people died because they believed the pseudoscience, and ultimately these delays in provision of antiretroviral therapy are estimated to have resulted in the loss of more than 350,000 lives. Fortunately, those days are over, but these early experiences as a young doctor were formative for me. So I did what most doctors of my generation did, and I went to work in the United Kingdom. While I was there, I decided to do a master's in international health and tropical medicine, a forerunner of global health. I arrived shortly after the publication of the Mwanza trial results. This was a large community-based randomized controlled trial of improved STI treatment to reduce HIV infection. And I learned that randomized controlled trials are considered the gold standard for generating evidence to change policy. The act of randomization balances participant characteristics between the groups, allowing attribution of any difference in outcome to the study intervention. The trial created a stir because it was the first example of a large trial to demonstrate the effectiveness of a biomedical intervention on HIV incidence. And I was gripped by the idea that you could change public health policy through high-quality evidence. So I joined Wits RHI, or RHIU, as it was then, and began my long-standing collaboration with Professor Helen Rees, my boss, my mentor, and my friend. This is a picture of my daughter, Tsiamo, who was 1 at the time, so she is a yardstick for how long I've been at Wits RHI. The first trial that I worked on was a trial of periodic presumptive therapy, or monthly antibiotic treatment, compared to syndromic management, which was the standard of care to reduce sexually transmitted infections among sex workers, and by extension, potentially protect them from HIV. The study was designed as a cluster randomized controlled trial, with hotels in Hillbrow being the unit of randomization. 12 hotels out of a possible 20 were willing to participate in the research and were included in the study. Hotels were randomized by simple randomization in a ratio of 1:1 to receive either periodic presumptive treatment with 1 gram azithromycin plus syndromic management, or syndromic management alone. There was a concern that participants might migrate to the periodic presumptive treatment hotels if allocation was not masked. So participants in the control hotels received monthly vitamin supplements. Female sex workers were invited to attend monthly clinics in each hotel, and the median follow-up ranged between 3 and 5 months. 98% of participants remained in the group in which they were originally assigned, and overall we saw a significant reduction in the prevalence of chlamydia and gonorrhea in the periodic presumptive treatment group compared to the syndromic management group, although both groups had a decline in STIs over time. We also conducted qualitative research that found that hotel-based services were acceptable to sex workers and actually had the consequence of reducing stigma. We also did a cost-effectiveness analysis with colleagues at the London School of Hygiene and Tropical Medicine and modeled the potential impact on HIV. Targeted interventions are thought to be especially cost-effective in early concentrated epidemics, but here was evidence of their cost-effectiveness in a generalized epidemic. The intervention resulted in 53 HIV infections averted and 1,413 DALYs averted, 4/5 of which were the result of the STI treatment. The cost-effectiveness ratio of the intervention was $78 per DALY averted, which fell within acceptable limits for HIV prevention interventions at the time. And the data supported the value of targeted STI interventions in generalized epidemics, and the value of early intervention, and ultimately contributed to WHO recommendations. At the time, consideration was being given to the decriminalization of sex work. we were invited to submit a friend of the court application to the Constitutional Court, along with Sweat and Kells, and to make the public health case for the decriminalization of sex work. Some of you may remember that I spent much of the WOMAD Music Festival in a tent writing this application. Despite our best efforts, the application was not successful. I learned several important lessons from this experience, though, including that health is shaped by your context, that individuals who are stigmatized and criminalized have limited individual agency, that laws can also be barriers to public health, and that we need biomedical tools to prevent HIV. So I decided that I wanted to learn to be a better scientist, and so I returned to the London School of Hygiene and Tropical Medicine periodically to do my PhD in clinical epidemiology. There was still a search for effective biomedical interventions to prevent HIV at that point. And at the time, although at the time 2 other community-based trials had not replicated the findings of the Mwanza trial, and there was some debate about the value of STI treatment for HIV prevention, there was a lot of interest in the potential of treatment of herpes to potentially reduce HIV. Herpes is a ubiquitous sexually transmitted infection. It's acquired soon after sexual debut, and it's lifelong. It's often not recognized, and at the time of these studies, about half of the population had herpes. And a substantial amount of observational data had demonstrated the synergies between HSV and HIV. On the one hand, HIV alters the natural history of HSV2, leading to more frequent recurrences or genital ulcers, many of which may be subclinical. But HSV2, on the other hand, has been shown to be associated with an increased risk of HIV acquisition. And the most recent meta-analysis had estimated that women may be up to 3 times more likely to be infected with HIV if they had HSV2. There were fewer data about the risk of transmission, but HSV2 had also been shown to be associated with HIV disease progression by altering viral set point. And the mechanism of action for these interventions appeared to be upregulation of HIV replication in cells co-infected with HSV2, and the recruitment of activated CD4 cells, which are HIV target cells, to the sites of mucosal disruption or ulceration. However, there were no randomized trials to confirm the causal relationship between HSV2 and HIV. At this point, I have to credit the laid-back and relaxed nature of my husband, Linswe. I returned home from London 6 weeks before our wedding, having done a stint on my PhD. He picked me up at the airport and took me for a dress fitting with a designer he'd found. We pretty much arranged everything for the wedding in the remaining 6 weeks. But for those of you who were there, you'll remember that it was a great celebration. So began a number of trials to evaluate the relationship between herpes, the potential impact of herpes suppressive therapy on HIV acquisition and transmission. And so began a long-standing collaboration with Professor Connie Callum at the University of Washington. We were added as a site in the HPTN 039 trial that aimed to determine whether daily suppressive therapy with acyclovir, that's taking a pill a day to treat herpes, could reduce HIV incidence. At the time, we knew that daily suppressive therapy could reduce herpes shedding by up to 80%. The trial was multi-centered and enrolled over 3,000 participants. There was no significant difference in HIV incidence, despite observing a 47% reduction in genital ulcer incidence, which provided reassurance that participants were taking their treatment. These findings were also confirmed by a similar trial in Tanzania. A subsequent biopsy study found that herpes actually reactivates more frequently for short periods of time, and during these periods of reactivation, a large number of activated T cells are recruited to the subdermal layer, and those little green fluorescences are CD4 T cells in a skin biopsy. And these cells persist for weeks. So often, even if the subsequent herpes has disappeared, any herpes or non-mucosal or non-infectious mucosal ulcerations at the area can lead to infection because of the high number of HIV susceptible cells just below the skin surface. So this next trial was part of my PhD, and in this trial we aimed to determine the effectiveness of daily suppressive acyclovir for reduction of HIV genital shedding in women living with HIV. HIV genital shedding was seen as a potential proxy for HIV transmission. And while we didn't see an effect of HIV on detection of HIV, genital HIV at the final visit, we did notice a cumulative effect of suppressive therapy, which led to significant decreases in genital HIV detection over time. And we also saw a modest reduction in HIV plasma viral load, which we weren't really expecting. So this was accompanied by an expected reduction in genital HSV detection, which provided support for the idea that people were taking their medication. And these data together provided support for the idea that herpes suppressive therapy, by reducing HIV plasma viral load and altering the pattern of genital HIV shedding, could contribute to the reduction of sexual transmission of HIV. This hypothesis was evaluated in a large multi-center trial of HIV serodiscordant couples, where it was evaluated whether daily suppressive therapy in the partner living with HIV reduced transmission of HIV to the uninfected partner. Sadly, acyclovir suppression did not reduce HIV transmission, although genital ulcers were significantly decreased, reinforcing that people had been taking their medication. We also saw that plasma HIV viral load was reduced, and that this actually translated into a reduction in HIV disease progression, although it was modest. But the lack of efficacy of acyclovir in reducing the transmission of HIV in our study really suggested that whatever we were going to do to prevent HIV, we needed to see bigger reductions in HIV to reduce the risk of transmission. And we also needed greater reductions in plasma HIV viral load to be achieved with other biomedical prevention strategies if we were going to prevent HIV. So I learned a few important lessons about the value of well-designed trials to answer important public health questions. We learned that more powerful tools were needed to prevent HIV, and secondary data analyses also provided important insights into HIV and HSV transmission in particular. We did change syndromic management guidelines on the basis of the evidence from these trials, but despite changes to the guidelines, the burden of access was still too high for patients. And ultimately, effective antiretroviral therapy may be more important for reducing the impact of recurrent herpes in people living with HIV than suppressive therapy. Fortunately, this cutie had arrived to keep me distracted as well. So careers are not linear, but after the herpes trials, there was an opportunity to explore whether the lessons about the interactions between viral sexually transmitted infections could be applied to another viral sexually transmitted infection, HPV. And I'll return to the HIV prevention story later. So HPV is what we call a necessary cause of cervical cancer. Not everyone who gets HPV goes on to develop cervical cancer, and the majority of HPV infections in young women are transient and self-limited and usually clear within 12 months. But around 1 to 2 out of 10 women don't clear their infection and go on to develop persistent infection. And only women who develop persistent infection are at risk for developing precancerous lesions, or CIN, and invasive cervical cancer. This is the reason that HPV is susceptible to prevention interventions, because of the long time between initial infection and the development of precancerous lesions prior to the development of invasive cancer. For many years, the main strategy for prevention was the detection of cells of precancerous lesions, and that's what you know as a pap smear. But in collaboration with Philippe Mayode, who'd been my PhD supervisor, we embarked on a collaboration to study in South Africa and Burkina Faso approaches to cervical cancer screening in women living with HIV. And this is because we had observed that women living with HIV had higher rates of HPV infection with multiple types, and appeared to be more easily develop precancerous lesions and less likely to have regression of lesions. but few studies had really addressed the question of what screening approach should be used. So the study, called the HARP study, enrolled women living with HIV at a time when antiretroviral therapy initiation was still determined by a CD4 count, so only 2/3 of people were on antiretroviral therapy. What we saw was kind of what we know today as the observation, that we saw very high rates of high-risk HPV, and high-risk HPV detection was more frequent in people who'd used antiretroviral therapy for less than 2 years. We saw a similar trend for detection of CIN2 or precancerous lesions. People with CIN2 have a high likelihood of developing cervical cancer if you don't go on to intervene. And progression to CIN2 was lower in women on antiretroviral therapy. This really highlighted to us the importance of effective antiretroviral therapy as an important strategy for cervical cancer control. We also saw similar trends for anogenital lesions and anogenital warts among men living with HIV. And the high burden of infection and disease in people living with HIV also emphasized the importance of effective prevention strategies in this population. So in the HARP study, we showed that while HPV DNA, which was the test that had been shown to best predict reductions in cervical cancer incidence and mortality, while it had the best sensitivity for precancerous lesions detection, it had poor specificity, and this meant that many people were referred for colposcopy even if they were likely to clear infection on their own. From a health system perspective, this was not really desirable, and already in the study what we'd seen is that women were experiencing prolonged delays in accessing colposcopy services. Although detection of HPV, while refinements could be made to the detection of HPV, it turned out that the status quo using a pap smear was optimal for the detection of precancerous lesions. These findings were discussed in consultations on the cervical cancer policy. And personally, at this point, I became frustrated with the focus on the test rather than fixing the system, because screening and the test is just an entry point to linkage to care, and that is what we were failing to do. I became more and more interested in the potential for primary prevention using HPV vaccines that could prevent cervical cancer. So despite initial misgivings that an HPV vaccine could be developed, several trials demonstrated high efficacy against vaccine-specific HPV types and precancerous lesions in populations who'd not had previous HPV. No excess safety concerns were identified in trials or in post-marketing surveillance, and in 2008, WHO recommended HPV vaccines be introduced in countries where cervical cancer burden was high. In 2008, the Minister for Health in South Africa announced that we would also introduce HPV vaccination. And so prior to introduction of the program, we conducted a study to understand the acceptability and feasibility of HPV vaccination and the approach that should be used in terms of the target population, the age group, and the delivery strategy, as well as the venue for delivery. In the study, we provided reassurance about the acceptability of a schools-based program for young girls, and also flagged up concerns about cost, capacity, and consent. There were a number of other activities that I was also fortunate to be part of. And in 2014, South Africa introduced the National HPV Vaccination Program, targeting grade 4 girls aged 9 years or older in public sector schools. The program delivers 2 doses of the bivalent vaccine 6 months apart and is offered as part of the broader school health program. So shortly after the introduction of the first dose, the Department of Health invited us to do an assessment of first dose implementation. And what we observed was that over 350,000 grade 4 girls were vaccinated in more than 16,000 public schools across South Africa, which translated into about 87% age-eligible learners being vaccinated. So at around this time, the Director General of WHO announced the call for cervical cancer elimination. And the goal would be to eliminate cervical cancer as a public health problem within the next century. So many of us are not going to be around. And in order to achieve these, set out a series of ambitious targets based on mathematical modeling, which need to be reached by 2030. The goals are that 90% of girls be fully vaccinated with the HPV vaccine by 15 years of age, that 70% of women are screened with a higher precision test at age 35 years and 45 years of age, and that 90% of women identified with cervical disease receive treatment and care. But the South African program wasn't achieving those targets. Even at the beginning of the program, we'd never achieved 90% coverage of one dose, let alone 2 doses. Administrative coverage rates for the first dose were high, but lower for the second dose. And on average, single dose coverage was 75% pre-COVID, but 2-dose coverage was only 54%. There are a number of barriers to the delivery of HPV vaccination programs, including the vaccine cost, the delivery cost because it's being delivered within a school and not a health system into a population that is not generally vaccinated, and so adds to complexity. But also there was a period of supply constraints and the emergence of vaccine or loss of vaccine confidence. So one of the questions that emerged because of some evidence that existed was, would a single dose of vaccine be sufficient to protect against HPV? And so we did this study called the HOPE study to evaluate the impact of a single dose of HPV vaccination on HPV 16-18 prevalence in adolescent girls and young women in South Africa. And we collaborated with colleagues in Australia. The aims of the study were to measure the population impact of our single dose schedule delivered as a catch-up to adolescent girls in grade 10, which is not the usual target age group for this program, and to evaluate protection against HPV 16 and 18. And we also wanted to know whether HIV status would affect the impact of a single dose. The design of the study involved 3 cross-sectional surveys, a baseline survey in 2019 in a population that wouldn't have been eligible for the national HPV program, and then a survey in a similar age group, 17 to 18 years, in 2021 to measure HPV 16 and 18 prevalence. And we also completed a survey to measure the impact of the national program last year. So the catch-up campaign was done in a single district in the Free State with a population that had 66 high schools and 6,700 grade 10 girls, and all of them were invited to receive a single dose of HPV vaccination. We followed the national program procedures, including getting written consent from caregivers, and we achieved 72% coverage, which is pretty similar to the national program. And this is what we saw. Now, this is impact on the population prevalence of HPV, but what we observed is reductions in vaccine-specific HPV 16 and 18. We also saw some evidence of cross-protection with reductions in HPV 31 and 45, but no effect on non-vaccine high-risk HPV types or low-risk types associated with genital warts. And what is also striking is that we didn't see any difference by antiretroviral therapy status. So we shared our findings with a number of bodies, and in 2022, WHO recommended an update to the HPV vaccination schedule, which allowed for a 1-dose schedule for girls 9 to 14, but raised questions still about the evidence for women living with HIV. So South Africa has been one of the countries to quickly follow suit, based in part on the data that we presented from the HOPE study. But there are concerns about whether single-dose vaccination will be sufficient for women living with HIV. And so we have embarked on a second HOPE study to answer the question of whether immediate or delayed non-valent HPV vaccination among women living with HIV who received 1 dose of HPV vaccination prior to HIV diagnosis can have an impact on high-risk HPV types. Back to that fork in the road. So in a parallel universe, things were moving in terms of HIV prevention. In 2011, research provided clear and unequivocal evidence that antiretroviral therapy and PrEP worked for the prevention of sexual transmission of HIV. And the question was, we know the what about the how? So in 2016, the South African government introduced PrEP for sex workers and gradually expanded the program. And now South Africa accounts for the majority of PrEP initiations globally. But one of the challenges that we observed was that almost half of oral PrEP users in Africa discontinued PrEP within 6 months. And while PrEP is meant to be for a season, there were a number of reasons for discontinuation, including lower perceived risk, side effects, pill burden, adherence challenges, lack of family support, and costs. And other studies had showed that stigma, discrimination, fear of partner violence, and poor mental health also played a role in discontinuation. So we then spent a period of time looking at whether we could develop strategies to optimize oral PrEP persistence. We evaluated drug-level feedback counseling. We evaluated adherence clubs that delivered an empowerment agenda. We looked at the potential for cash incentives to sustain PrEP adherence. We also evaluated mobile health adherence strategies using SMS or WhatsApp. And we also looked at integrating a mental health intervention into PrEP services. Unfortunately, none of these interventions contributed to ongoing PrEP persistence. The only intervention that had some effect was the use of a decision support tool, which meant that people who were exposed to the decision support tool were twice as likely to persist on oral PrEP at 1 month. And so it reminded me of a study that we had done evaluating a tenofovir-based microbicide called the FACTS trial. Because in that study, what we learned was that sexual intimacy for young people was largely unpredictable. It often happened across multiple locations, and women often had limited privacy, autonomy, or control over the timing of sex. And this made adherence to the dosing strategy challenging. In this study, people were required to insert a gel before sex and after sex, and the second dose might have been more frequently missed than reported. But what it highlighted is that it's not always possible to change the social and structural environment in which people live. And what we actually need are alternate safe and effective products that are less user-dependent. And it also confirmed the importance of large randomized trials to confirm early initial findings. So now we're in the era where we know that people want long-acting agents for PrEP. Most but not all studies in cisgender women have generally shown a preference for injectable PrEP over daily oral pills, although there are some differences by geography. So began the HPTN 084 study. This was a randomized controlled trial of an injectable drug called cabotegravir, which is an antiretroviral, and because of its physicochemical properties, it can be injected every 8 weeks for pre-exposure prophylaxis. The trial compared injectable cabotegravir to the use of daily oral pills, and because the trial was blinded, people received either a dummy cabotegravir and an active tenofovir pill, or active cabotegravir and a dummy tenofovir pill. And participants started with oral pills, and after 4 weeks, if the drugs were tolerable, they then moved to the injection phase, which was an injection. The first 2 injections were 4 weeks apart, and then injections every 8 weeks. And participants returned for these visits every 8 weeks, and at each of these visits we did HIV, pregnancy testing, and safety assessments. In some instances we had additional post-injection safety visits, and we also provided real-world adherence counseling aligned to national guidelines. And this is what we saw. This, in fact, was the first HIV prevention trial I'd been involved in with a positive result. But what we saw is that in the HPTN 084 study, compared to daily oral pills, injectable cabotegravir given every 8 weeks reduced HIV infection by nearly 90%. This was in cisgender women, and in a companion trial in cisgender men who have sex with men and transgender women, they also saw similar reductions in HIV incidence. These effects were sustained 1 year post-unblinding, and open-label studies continue to demonstrate the effectiveness of injectable cabotegravir for PrEP. There were consistent effects by age, race, gender identity, and region, and this was different from what we had seen, in fact, in other trials of pre-exposure prophylaxis, where there were differences in effect by age. And so within a year, injectable cabotegravir had been approved for PrEP by the FDA, and this was also followed by the EMA and a number of national drug authorities, including SAPRA. And by 2022, injectable PrEP was recommended by WHO as cabotegravir was recommended as PrEP for all populations. So what have we learned about cabotegravir and injectable PrEP since the results? The study has moved into an open label extension, and what we have observed is a strong preference for injections over pills, expressed during both the blinded period, even when they were using both. The nearly 8 out of 10 women in HPTN 084 chose injectable cabotegravir for PrEP, and 92% of those under 18 years in a sub-study in adolescents opted to continue their cabotegravir injections. This is because people found injections convenient, discreet, and easier to adhere to. And we also observed that those people who chose cabotegravir appeared to be at higher risk for HIV, and were clearly assessing their risk because they were more likely not to live with their partners, have experienced recent intimate partner violence, and to have paid for sex. We also learned something about what has been called the Levi phenomenon, which is really the impact of these very potent antiretrovirals on routine HIV diagnostics. Firstly, HIV infections are extremely rare in people using injectable PrEP. But what we have observed is that cabotegravir delays detection of HIV with conventional diagnostics because it suppresses viral replication and delays antibody production. And this prolonged monotherapy may lead to resistance in rare cases. So this has led to people evaluating the use of a sensitive HIV RNA assay to detect early infection. But this is going to be too costly in a region like ours, and also logistically infeasible to implement. And so we've, in the open label extensions of both 083 and 084, have evaluated the utility of HIV RNA. And as it turns out, it's probably more trouble than it's worth. So another important thing about accelerating antiretroviral access for HIV prevention has been the importance of not leaving anyone behind, including adolescents, but also including pregnant and lactating people who often desire to fall pregnant without the fear of HIV. So in the open label extension, one of the things we did was to evaluate the safety of injectable cabotegravir during pregnancy, as well as whether we needed to do dose adjustments. And what we presented in Munich this year is that maternal pregnancy and infant outcomes were consistent across non-randomized exposure groups, and also consistent with background rates. There were no maternal deaths or HIV infections, and there were similar rates of poor pregnancy outcome, irrespective of whether people received active CAB, prior CAB, or had never received cabotegravir. Cabotegravir was well tolerated in pregnant women, and we didn't see any of the side effects that people have been concerned about with integrase inhibitors in pregnant women. So these data provide reassurance regarding the use of CAB in populations where both pregnancy and HIV incidence are high, at a time that we are rolling out cabotegravir as part of national programs. And we will continue to accrue safety information given the higher pregnancy incidence in HPTN 084. We also saw that there were no requirements for dose adjustment in those that became pregnant on CAB. So one of the other things we did was to evaluate the cost effectiveness, pricing, and access. And what we were able to show is that cabotegravir proven effectiveness means that it is more effective than either medical male circumcision, condoms, or antiretroviral therapy unless it's used perfectly. And in South Africa, cabotegravir could prevent up to 30% more HIV infections over 20 years. more than any other intervention that's been evaluated in the investment case. This is over an HIV program in which all other interventions are already routinely offered, and the first and the third 90 in the 1990 targets have been met. But the addition of cabotegravir substantially increases the cost of the HIV program and remained unaffordable to South Africa despite our contributions to the global trial. Fortunately, we received the good news a couple of months ago that the South African government has accepted a donation of cabotegravir from PEPFAR, and hopefully we will see cabotegravir rolled out either toward the end of this year or early next year. So, what does the future hold? Well, coming full circle, what we have seen in PrEP programs with people at high risk of HIV is that they're also at high risk of sexually transmitted infections. And given our experiences of HPV, but also kind of the demonstration that we can produce tools to prevent HIV, we are now looking forward to the opportunity to work on vaccines to prevent HIV, and both for pandemics like Mpox, but also in response to antimicrobial resistance like gonorrhea. But I think what I've learned working in global health for the last 25 years is really that the value of an innovation lies in the using of it. If we can't get it to the people that need it, it's not useful at all. What I've also learned about global health is that infectious diseases reflect social inequalities and disparities in health access. We can make tools to level the playing field. We need to advocate for the value of science as a tool for development. Earlier incorporation of end-user preferences and health system requirements can lead to better uptake and impact. Social influences are still going to impact uptake, and we need to be aware of them. Don't fall in love with your product. It will disappoint you. Progress is incremental, so believe in yourself when it feels like nothing works. And fundamentally, collaboration and mentorship are critical to the success of global health. So there are a lot of people here that I want to thank, all of you, but also a number of people who I've worked with over the years. And I've probably forgotten to name a few, but I think the person I want to call out most is Helen, who took a chance on me 25 years ago and allowed me to work in an incredible organization which is led by women, and it really created the space for me to develop into the scientist I have over the last 25 years, and to continue to do exciting work that can have an impact on global health in my lifetime. So, and lastly but not least, to all of you who've stuck by me on this journey, I really appreciate it, including my family and friends who've had many times where I've not been available to be there to celebrate important things. So I really appreciate you all being here today. Thank you very much.
Sinead. Sinead, thanks for sharing with us what is really a remarkable journey. A remarkable journey as a scientist, a remarkable journey as a health advocate. I think what you demonstrate is the type of research which takes place at Wits, which has an impact not just in South Africa, but at a global level. And it's also delightful to see someone from Wits really leading the field internationally. So once again, congratulations on a well-deserved promotion. The one thing which I think probably usually goes by rather under-recognized and under-mentioned is the sacrifices that are made in people like yourself being able to achieve the type of accomplishments you managed to achieve, and that is your family. I think often as researchers we don't truly appreciate the tremendous sacrifices that families go through for people to do what they're really passionate about. So to your family, thanks for sharing Sinead with the faculty and with science in general. So I would now like to call upon Prof. Helen Rees to give a vote of thanks. Prof. Rees probably doesn't require much of an introduction, but protocol demands that I do read out something about her. So Prof. Helen Rees is an internationally recognized as an award-winning global health practitioner who has dedicated a professional career to improving public health in Africa with a focus on vaccine-preventable diseases, HIV, and sexual and reproductive health. Helen is the Executive Director of the Wits Reproductive Health Institute, the largest research institute at the University of the Witwatersrand and probably on the African continent. Helen founded Wits RHI 30 years ago. A medical doctor by profession, she is a personal professor at the university in obstetrics and gynecology. She is also the co-director of the African Leadership in Vaccinology Expertise, a Wits University flagship program. Helen is also an honorary professor in the Department of Clinical Research at the London School of Hygiene and Tropical Medicine. She is an honorary fellow at Murray Edwards College, Cambridge University in the United Kingdom, and she holds the Doctorate of Science honoris causa from the University of London and the Doctor of Laws honoris causa from Rhodes University. Helen has been rated as the South African National Research Foundation scientist twice and was commended on the high quality and impact of her research outputs, as well as the international standard. Helen.
Well, that was a tour de force. So wonderful. Well done. That was fantastic. Thank you. So, Professor Ian Jandrell, I'm sure you learnt a lot through that. Yes, I could hear it. Really? Comments coming out here. And Shabir, thank you so much also for being here. And Linswe and Siamo and Atlile. And I think the extended family, if I asked you to put up your hands, I understand there's quite a few of you here as well. So yeah, there you go. Quite a lot. But again, thank you. I totally agree with Shabir. I mean, the amount of time that this takes is huge. But I wanted just to say, you know, the first time I have a very strong memory of meeting Sinead for the first time when I was desperately actually trying to recruit people to come and work with me. We were 5 people at that stage. And there were 2 things that absolutely struck me. She'd come in from London. I think you were still going back to London. No, I think you popped in. Anyway, we had an interview, and 2 things that struck me. One was these incredible blue eyes. Yeah, have a look next time you see her. And the other one was, thanks to Linswe, that she was hugely pregnant at the time, I think, which actually equally surprised her family. But things happen when you go to London, clearly, beyond masters. But, you know, I think the one thing that I would say, and that you could probably hear, but typical Sinead was kind of hidden in the science, is that she's a global top researcher, absolutely global. That cabotegravir trial was really the first absolutely breakthrough study in HIV prevention, with, as you saw, nearly 90% protection for women. And Sinead led it globally, yeah. But she's also been made, which she wouldn't also tell you, the head of, from the National Institutes of Health. Those of you who aren't in the research world, National Institutes of Health is the biggest international donor from the US government. And they fund what are called clinical trial units around the world, particularly focused on HIV, but now sexually transmitted infections, and probably will expand further. But they have a huge prevention arm, which is covering many countries in the African region, many countries in the US. And that prevention arm has just voted for new leadership. Sinead is the co-international leader. So, but what I will say is that if you have someone who's such a dedicated researcher, The one thing about Wits RHI, there's a bit of a tradition of playing jokes on people. And we did this one day. We were all at a retreat. There were about 50 of us there. And Sinead said she was going to be a bit late arriving, I remember now. So we all plotted. It was her birthday. And so we all plotted that we would, I would take her to one side. She'd come in the room. I would take her to one side, and I would say, really bad news, which I did. So I said, listen. So she came in. I took her outside. She probably came in thinking we were going to sing happy birthday. But I took her outside, and I said, listen, got really bad news. We've had a break-in in the clinic. And the worst thing you can say to a researcher is, all the files have been stolen. And Sinead believed it, because it's the worst thing you can say. It's like, oh, it goes to your soul, you know. And then she came in the room, absolutely saying, well, what do I do? And then everyone sang happy birthday, and it was clear that it clearly hadn't. But I just want to say, Sinead, I think we just recently had a Faculty of Health Sciences research retreat to say, what can we do? And I think, you know, I think you are somebody who, in a team, I can tell you the team, the leadership team, some of them are here from Wits RHI. You have some of us, we know our personality types, who will open our mouths before thinking. And you have some who are the enthusiasts and get on the road and want to roll on. And then you have Sinead, who's the thinking researcher, who sits back and says, hold on a second, and pulls you back a bit. And that balance has been huge for the success of Wits RHI, the balance between the leadership. And so I think for that I want to say thank you. But I just also want to say something else, which is very important, is that at a time where people are looking for African scientific leadership, having an African woman who has contributed so much is absolutely outstanding. And I suspect that many people in the room didn't realize how much you have contributed and will continue. So thank you very much. So with that, I think thank you all very much for coming. You know, I think we said, I understand there's quite a lot of friends here, so I understand that the renter crowd went out and we filled the seats, so thank you all. But thank you all very much. There are many Wits RHI colleagues, there are colleagues here from the university, from Wits Health Consortium. There are activists here in the room. You can see him afterwards. But thank you all so much for coming, and we will now go out as a procession first, and then if we'll invite everyone to come upstairs and have refreshments. So thank you very much indeed. Well done, Sinead.